Everyone, I'm one of the first year cardiology residents, and it is my pleasure today to present my talk on normal variants, which perhaps more aptly should be named is that a thrombus, as you will see shortly. And thank you everyone for both coming in person as well as on Zoom. So my objective today first is to introduce some of the common and less common normal variants that can be seen on 2D transthoracic echocardiogram, and to compare some similarities between the normal variants and pathologic findings, and to discuss clinical significance of these findings, as well as briefly, very briefly, explain the embryological basis for these normal variants. So as everyone's familiar with echocardiogram, it's a quick, simple, fairly non-invasive test that's helpful in identifying anatomy and hemodynamics within the heart. You can see the chambers, the valves, the muscles, some of the blood vessels, the pericardium, as well as beyond. Every now and then we come across these findings on echo and you're like, I don't know what that is. Is that a thrombus? Is that a vegetation? Or that's actually normal? So that's what we're going to go through today. So this is a peripheral long RV flow view. What I'm trying to show at one is this sort of linear structure here. And the other thing is a bit hard to see is a little flippity thing in this black area. So I don't know what these are. Yeah, which one is the eustachian valve? Yeah, this one. That's the flippity. Okay. Any other guess?
So that's also known as the eustachian ridge.
The eustachian ridge, yeah.
Yeah, in the one that is lower, the lower red arrow.
Yeah.
Which guided the inflow of the IVC across the integumental septum, so we can get the nutritious blood from our mother's placenta.
So exactly. So this is a Sebastian valve, which is at the entry/exit of the coronary sinus, and I'll go into a bit more details about what it is later. And this is eustachian valve or eustachian ridge, which were embryological from them. So we'll start with the Sebastian valve first. It's called the gatekeeper of the coronary sinus, as I implied. It's right at the exit of the coronary sinus. It prevents retrograde flow into the coronary sinus during atrial contraction. Generally, it's fairly benign. But as you can imagine, if the valve remains quite big, it can obstruct coronary flow, and it can be a problem in biventricular pacing when they put the wire through the coronary sinus. So this is a TEE of the exact same patient, and you can see here a lot better. This is a coronary sinus, and that flippity thing, it's a very thin valve. It's often you can't see it on TT because it's so thin and so small, but that's very well visualized. So little history of medicine moment, because the heart has all sorts of beautiful names. Who is Sebastius? This is the guy. He is very old. He was born in Poland in the 17th century. So at 22 years of age, he presented his graduate thesis. I'm not going to try to pronounce his title, but it really made major advances in our understanding of the coronary venous system. So it was not only the valve that was named after him, but also the veins, the Sebastian vein, that also named after him. Makes me wonder what I was doing at 22, but that's okay. All right, moving on here. This is technically a TEE view, again, of the RV inflow. Another flippity thing over here. Any guess? Yeah, so it's hard to see. That's the eustachian valve in this view. So that's the IVC coming in. It looks like the Sebastian valve, but it will really have to based on the location. So it can be quite challenging sometimes to tell. So eustachian valve is an embryological valve of sinus venosus, which I'll explain in a bit. In uterus, it helps direct the blood flow from the IVC to fossa ovalis to bypass the fetal pulmonary system. There is not really much physiological consequence, but it can be confused with a thrombus. It's not as obvious in this view because it looks fibrin-like and highly mobile, not necessarily a thrombus, but in certain views it can be. It can become a site for endocarditis because it is a valve, and it become a nidus for thrombus formation. It's pretty common, can be found in 25% of individuals. I'm sure a lot of you have already come across when you were scanning. So who is Eustache? I looked it up and how to pronounce it. I actually thought it was some sort of mythical background, but it's actually a physician. So Bartolomeo Eustache was an Italian anatomist. He described multiple things. So not only the heart, but also dental pulp, periodontal membrane, thoracic duct, obtusus nerve, adrenal glands. Yesterday, someone asked me, eustachian, isn't that in the ear? It actually is. So there's the eustachian tube, eustachian amygdala, the canal for the eustachian tube. They were all discovered by this guy. Essentially, yes, chest up. Yeah, he was a very prolific anatomist, and he was so old that he used to draw anatomy on copper plates. So fortunately, I don't have a picture of that, but it would be cool. All right, moving on. What is that? The typical four-chamber. I'm hearing everyone whispering Chiari network. Yes, this is the Chiari network. So it's mostly associated with the IVC opening. As you may see earlier when I explained the embryologic basis. It may also attach to other things. So the right atrium wall, the interatrial septum, or the coronary sinus. It has this classic spiderweb flying in the wind appearance, which is quite well characterized in this clip. And it is often associated with the patent foraminal valley, interatrial septal aneurysm, and sometimes prognostical embolization, but the frequency of that is really fairly debatable. It's relatively less common compared to the eustachian valve, can be found in about 2 to 3% of individuals. Moving on. It's still the Chiari network. I just found a couple more clips. Now, in terms of the clinical significance, it's thought to not cause much trouble, but as you can imagine, using the right atrium, when we put in PA catheter or any sorts of pacing wire, it can cause entanglements of the catheters. It can be mistaken for endocarditis if the attachment is closer to the valve. It can be thought as a flail leaflet, a tumor, or thrombi. So it really depends. It requires multiple views to see the attachment to really make sure that this is not anything pathologic. This is still the Chiari network. It looks like a jumping rope here, not necessarily a spider web, but it's very flippity. Now, move on to history of medicine. Who is Chiari? This is the guy. He's a bit more modern. He's an Austrian pathologist from the 19th century. He also was very prolific during his career. He was named multiple phenomena were actually named after him. So Arnold-Chiari malformation is a malformation in the brain that can cause trouble, and Budd-Chiari syndrome is due to thrombus formation in the hepatic system causing acute liver failure. So they are all named after the same person. All right, moving on. What is that on the valve? Right here. Yes. It looks like it's tethered to the valve, and it looks round with sort of like almost like a hollow center. That's not the proper term, but so the initial echo report thought this might be a tumor, not necessarily a thrombus. It doesn't quite look like it, but it was sinister looking enough to warrant further imaging because it's not entirely clear what that is. So once we do the TEE, what do people think? See that? Yeah. So that's also still the Chiari network, actually. Over here is the eustachian valve, and you can see that it's attached. So the initial TTE show that it's attached to the valve. And in fact, a few of the earlier views in the TEE also show that it was attached to the valve, making it look quite sinister. But upon further viewing, in the excellent hands of sonographers, we were able to find other attachments. So it's attached over here, and in this view, it's attached to the coronary ridge because this is a coronary sinus. So based on these attachment embryologically, it is more likely just to be a very complex Chiari network. But as you can see, that this can be very easily identified as something sinister. Yeah, flippity. Wait, where's the mouse? Yeah, right here, right here. it's very faint in this view, and we have to pause it to see it. All right, moving on. What is that? Highly mobile. It's round. Looks bad to my eyes, but as you know, the top of this top probably not bad.
Sometimes get confused with a tumor or clots.
Yeah. So I won't torture you further. This is the crista terminalis. So it usually is found in the posterolateral wall of the right atrium near the SVC. It typically has similar echogenicity with adjacent myocardium. So as you can see in this one, it's quite with regular border, and it looks very similar to the myocardium around it. It almost looks like there's a stalk here, which would make the thrombus less likely, but it's tough to see in this view. What are these?
Not crystal terminal.
Yes, that's the point. These are actually thrombi as a comparison. So these are less uniformly echogenic compared to the last one. It is not attached to the atria wall, and it seems to be bouncing around, having a good party. So these are thrombi instead. So as you can see, they can look quite similar if you're not paying attention to it. So it looks like the right atrium have a lot of embryologic remnants, and so I think it's worth digging into why it's the case, and which explain why we're seeing them and where we're seeing them, which helps us also understand, help us differentiate them from pathologic finding. So my very brief embryological explanation. So in development of the heart, around 18 days, this is sort of what a fetus or the baby looks like. You have the cranial aspect, the caudal aspect, and you have sort of the area of cardiogenic area. So you have the cardiogenic area that develops eventually into the heart. So first, the mesoderm becomes two endocardial tubes, and the tube eventually fuse to form the primitive heart tube. And that heart tube differentiates into initially to 4, but eventually to 5 sections. From cranial to caudal, you have the truncus arteriosus, the bulbus cordus, the primitive ventricle, the primitive atrium, and the sinus venosus. So the truncus arteriosus develops into the ascending aorta as well as the pulmonary system. The bulbus cordus, as the heart rotates with the arrow pointing, it eventually becomes part of the right ventricle. The primitive ventricle contributes to forming the ventricle. The primitive atrium actually only forms part of the final atria that you see, while the sinus venosus actually contributes partially to the right atrium, as well as to coronary sinus formation as SVC, IVC, and the SA node. This is so as it rotates, you see that the atria kind of go upward, so more cranially, while the ventricle go more caudally around 35 weeks. This is just another cut of the primitive heart. So we start out with the primitive atria, primitive ventricle. There's no septum in between. So the septum premium kind of move towards the endocardial cushion in the middle, and form these 2 layers that eventually forms the foramen ovale. So why are these important? Why do we have so many vestiges? Well, during the fetal circulation, sorry, I'm gonna go a bit more about this. So here is particularly focused on the right atrium. So the sinus venosus, as I suggested earlier, contributes to the atria as well as the coronary sinus. So you have a left and a right, and the right sinus venosus eventually develops into these 2 venous valves, so left and right venous valve. And during fetal development, these valves help direct the blood to the left side of the heart rather than going through the ventricle. The left venous valve will continue to regress, while the right venous valve eventually forms the eustachian valve at the IVC, as well as the Bessine valve that we saw earlier. And the crista terminalis is formed between the primitive atrium and the sinus venosus. So as the sinus venosus develops into the atrium, it kind of meets the primitive atrium. So the more trabeculated part of the atrium comes from the primitive atrium, while the smooth part of the atrium comes from the sinus venosus. So this is just another diagram demonstrating how we can end up with these remnants. So these remnants are supposed to degenerate as we age, but sometimes they don't. So that's where you can see thickened terminal crest or the crista terminalis, as well as the valve present in the same individual, or you may just see the valve or just see the terminal crest. This is just a schema demonstrating the fetal circulation. So as the blood comes in through the IVC, the valves are here, and it helps direct the blood through the foraminal valley into the left side and bypass the right ventricle. And this is another view of the valve here. And this is what it actually looks like. So as you can see, the eustachian valve and the terminal crest are pretty thick structure. That's why they're quite obvious, while the thebescent valve is very, very thin. So it's hard to see. All right, that's enough embryology for now. Moving on, what are we looking at here? It looks almost like a tumor, but at the same time, it's flippity attached to the atria, coming in and out of view. So this is actually a septal aneurysm, mimicking a thrombus or tumor, depends on what you think. So it will require multiple view. So atrial septal aneurysm, it's defined by septal excursion more than 10 millimeter into either atrium. So as you can see, this portion is moving left and right. Granted, it depends on what guideline you look at. Some people say 15 millimeter, but basically something that's highly mobile going left and right. Generally seen better on TEE, but you can definitely see on TT. It's often associated with other congenital findings, such as patent foraminal valley, atrial septal defect, mitral valve prolapse, Marfan syndrome. The clinical significance, not sure. There's thoughts that it can potentially cause paradoxical embolism and stroke, but the prevalence is really not that clear. It's not super common. At autopsy, only about 1% of adults. Well, that's in mics, I would say everything seems more common than the literature. Moving on, what is this thick structure over here? Is that a myxoma? Yeah, exactly. So it's the lipomatous hypertrophy of the atrial septum. Defined as septal thickness greater than 20 millimeter and represents extracardiac adipose tissue between the right and left atria. It's generally benign. It's generally found in elderly. It's often associated with fat elsewhere in the heart, so pericardial fat as well. It represents for the metabolic deposit over years. The prevalence is not super high, anywhere from 1 to 8%. I guess it will depend on what age group you're looking at. Generally benign. All right, moving on. What are we looking at here? Coronary sinus. I hear whisper. Yes, that is the coronary sinus, a dilated coronary sinus.
No, we don't.
So it's not super common. That's fair. It's not super common actually, but like I said, SM mics, everything seems more common than the literature. It's present in less than 1% of the general population. Here's another view of the dilated coronary sinus looking from down up. The heart, it's usually due to a persistent left SVC, which I'll go into shortly. Here's another view. This is a bit smaller in the parasternal long view. And when you put an M mode through at the tip of the mitral valve, you see the anterior mitral leaflet, the posterior, and this black space behind. That's actually the coronary sinus coming in and out of view during contraction. So I think alluding to what Veen was, Veen was alluding to, that when you see this, you kind of have to get a definitive diagnosis, which will require bubble study. So you inject bubble into the left arm, and it should show up in the coronary sinus first before going into the right atrium, right ventricle, and eventually to the left side. So this is a very nice clip. And like I mentioned, the dilated coronary sinus is usually associated with the persistent less SVC. So here's a CT scan showing the SVC on the left side going into the heart rather than the right. So a little bit more embryology. Going back to what I was mentioning earlier, the sinus venosus contribute to the atria, but it also helps funnel a lot of the venous blood during embryology. So it is attached to two common cardinal veins, and cranially you have the anterior left and right cardinal vein that drains from sort of the head region, the cranial region, while the posterior cardinal vein drains caudally. As we develop, the sinus venosus contributes to the right atrium, and together with the cardinal vein, it helps develop the IVC, SVC, while on the left side, the left common cardinal vein is supposed to develop into coronary sinus that drains into the right atria, and the rest is supposed to become the ligament of Marshall, is supposed to become a remnant. However, in certain cases, this degeneration does not happen, so you end up with a left SVC instead, and as you can imagine, it leads to dilation of the coronary sinus, and you can see on echo. The most common finding is that you will have two SVC, left and right. More rarely, you will only see the left one. All right, what is that? A little tip, the atrium is quite big, and this patient had a heart transplant. So this is a suture line that you can commonly see. So the clinical context is important, otherwise you wouldn't know what it is. It's fairly normal finding post-heart transplant, normal variant among people with heart transplant. But I suppose that's not normal to begin with. Moving on. Yeah, that is the Coumadin ridge. And so this is the apical port chamber in the left atrium. You have this Q-tip-like structure. So this is the Coumadin ridge, also ligament of Marshall, which I alluded to earlier. It's atrial tissue between the left upper pulmonary vein, which drains in somewhere around here, and the left atrial appendage, which actually you can kind of see maybe. It's not commonly seen in the TTE, but it should be somewhere around there.
That's the left atrium.
Oh, there it is. It's embryological vestige of the left common cardinal vein, like I mentioned earlier. And it has this Q-tip appearance. So it's called Coumadin ridge because it's commonly mistaken for a thrombus. So in this view, you can clearly see its attachment, which is helpful, but as you can imagine, depends on how you cut the heart, then you might not actually see that stalk, and you might thought this is the thrombus. Hence, people are put on warfarin, Coumadin for it, hence the Coumadin ridge. However, the interesting thing is it can actually become an itis for paroxysmal AFib, which often would require anticoagulation. So maybe the name is quite apt.
Should be renamed as the NOAC ridge.
The NOAC ridge, that's fair. So here a little bit more embryology. I won't go into details, but as opposed to the right atrium, when you have the pyramidal atria and the sinus venosus that form the atrium, on the left side, you have the pulmonary vein as well as the primordial left atrium. As you can see, the part from the vein kind of evades into the primordial left atrium. So this usually is more of a smooth part, while this part usually is more trabeculated, and the Coumadin ridge is just sort of in the middle. And this is a very nice drawing that I thought. You have the vein here, you have the left atrial appendage, and it's just like a thick structure here, hence why it's so dense on echo. All right, who is Marshall? Who was Marshall? Here is a painting from Wikipedia, so take it as you will. I'm not sure if this is actually him, but he's someone from the 19th century who was a British surgeon. He contributed significantly to the surgical electrocautery, even though it is technically attributed to a different physician. He reportedly used it on a 25-year-old with recurrent fistula, but he didn't formally publish it, I suppose. He was also a microscopist. He was one of the first to show that cholera might be spread by means of drinking water. So kudos to him. Moving on, what is that? We see that quite a bit. Yes, it is false tendon. Thanks, Grace. That's a false tendon. It can be seen in the left ventricle. It has different So different attachment, it can be in the apical area or more towards the base, but typically this is the location, is transverse towards the apical. Generally, no significant clinical significant clinical use, but it can get ruptured when it gets dilated. It could potentially be a source of ventricular arrhythmia, but how common that happens is that whether it warrants intervention is really not the case. All right, moving on. What is that? Is that a thrombus down there? Yep. So, like I said, the talk, it really should be, is that a thrombus, but so that's not a thrombus in this case. It's actually just very heavy trabeculation. I won't go into the detail of trabeculation versus non-compaction, but it can be seen in normal echo and can be mistaken. What about that? That's now in the right ventricle. Is that a thrombus? Yeah, it's the moderator band. I think a lot of you were mouthing that. It generally is not as like, it's kind of similar to false tender in the left ventricle to some degree, and it's also called a septal marginal trabecula. It's common in 90% of the population. It's so common you might as well not call it a variant. But in certain cases, it can become quite thickened and resembles a thrombus, which yesterday in the echo lab we were debating over that for one case. Some of you might have seen this echo. Now the question, they're definitely thrombi in the left ventricle. I'm just going to give that to you, but are there thrombi bilaterally? Is my question. They do, don't they, in the right ventricle over here. That was the first offer. Pretty much everyone I've talked to who saw the initial echo, but as you put in some Definity, you can see that it's actually trabeculation. I'm not sponsored by Definity, but they definitely make the images look better. Here's another view, parasternal long, and you can see the right ventricle here is just very heavy trabeculation. But it certainly can be mistaken for thrombi in the right clinical context. I wouldn't be surprised if this patient were to have it. All right, moving on. What are we looking at here? So that's a papillary fibroelastoma. You can see there's a stalk here. So where's my mouse? There's a stalk here with a round structure that could be that looks like a tumor or a thrombus if you don't see the stalk, or even thought to be a vegetation, depends on how close it is to the valve. It is a benign avascular tumor, usually coming from the normal endocardium. It's typically described as a frond-like structure, which confused me because I don't know what a frond looks like, and this is a frond. It's basically just palm, it's fern leaves, and this is a baby frond. To be honest, I think that fibroelastoma looks more like this one, but this is what the frond is. Moving on, what is that? Looks like a myxoma. You know, it does. It certainly does, and that was definitely the initial thought. And it was not just the one in the left atrium. There's also the echogenicity over here in the aortic valve, and in this slightly off-axis short axis view, you can see that right here, which actually, given it's the right atrium, almost looks like Coumadin Ridge in this picture, but maybe not the right location. And the 2 of the 3 aortic cusp also appears to have something on it. But these are actually papillary fibroelastoma. Sorry, going back, this mutation later had them excised. So even though they're typically benign, but once you get beyond a certain size, they are at risk of embolizing. So this patient underwent surgery, and on pathology was confirmed to be a fibroelastoma. Maybe a bit hard to see. What I'm trying to point at is this flippity thing on the inferior aspect of the aortic valve. Yeah, it's a Lambo excrescens. It's a fibroelastic and avascular core, usually covered by an outer layer of endothelial cells. It's thought to be from wears and tears, so you have these microthrombi formation on the aortic valve over time. The clinical significance again is not super clear. There's some thoughts it can embolize and cause stroke, but we don't really chase after it when we do see it. It can be confused with vegetation, as you can imagine. It's right on the valve, and it often occurs at more than one location if you do see it. The prevalence kind of varies. Oh yes, there's that too. Dr. Chow was trying to point at that. It can be confused with vegetation, and the prevalence varies. So there's some thoughts it could be up to 80%, but on echo maybe only 40%. So, and on a zoomed in valve, you can see it much better here. All right, who's Lambo? This was Lambo. He was a Czech physician from Bohemia from the 19th century. He also described a protozoan parasite. Here's a question to the medicine resident. Do you know what it is? Yeah, Dr. Chow knows. It's Giardia, but how that come from Lambo? So it was first named Cercomonas intestinalis, and then it became Lambia intestinalis, named after Lambo. But then they also added Giardia in front of it because Giardia is another physician, and over time we just know it as giardiasis. Anyway, so this is a nice table comparing some of the findings around the aortic valve. So there's Lambo's excrescence. It's usually in the elderly, like we mentioned, is usually wears and tears. It's quite thin, fine thread-like, lynch-like. It's a great description. Doesn't usually cause valvular regurgitation. Papillary fibroelastoma is also similar, seen more in the elderly, but it's round, frond-like, usually with a stalk as opposed to Lambo's, and it usually is downstream from the valve, not necessarily on the valve. Well, vegetation usually needs to be interpreted in a right clinical context. Do they have fever? Do they have bacteremia? Do they have risk factors? But it tends to be more irregular, shouldn't have a stalk. And as one of the echo fellow likes to use, it's kind of shaggy looking. All right, moving on. We're looking at the aortic valve. What are these bright spots? Thoughts? These are sorry, I didn't hear what you said. Yeah. Nodules, yes. These are nodules aurantius. It's a great name. It occurs at the coaptation point of 3 or the cusp, as you can see in this view. It can actually contribute to aortic regurgitation if they're big enough. So they're not entirely benign. Now, who's Aurantius? This was Aurantius. He's so old that we don't have a painting, just a bust. He's from the 16th century, was an Italian surgeon. His Latin name was Julius Caesar Aurantius, hence nodular Aurantius. He was first to describe multiple structure, the foramen valley, the ductus arteriosus, although apparently some of these discoveries were attributed to other people, so take that with a grain of salt, but he definitely named the nodules. What I'm trying to point at here, maybe hard to see, is this space in the outflow tract, which you can kind of see in the video here. Yeah, it's the RCA. So it can, the reason I brought it up is that it can look like a dissection. So if you look at the other views, if it's that prominent, you should be able to see it in some of the other views. So for example, in the short axis, you can see this classic train track sign. I think it's just a track sign of the coronary vessel. So the LCA should be somewhere here, which you might or may not see. Yeah. Now, what is that? Is that still the RCA? Yeah, so this is actually a dissection. But what I'm trying to show is that if you look at this area, it looks actually quite similar to a dilated RCA. So right clinical context, I bet you also have, we also have to measure the aorta. This probably was dilated. But they can resemble each other. Oh, this video does not play. What do you think? That's just a pericardial fat. It can see that within the space, it's moving around with it, and it looks like there's stuff in it. Makes it more like the pericardial fat. Well, this one. Thoughts. Very small, but more like effusion. And then this one, where these clip are not the greatest. Yeah, so that's effusion and fat. So there's the fat right here. So if you, as you can imagine, if the effusion weren't there, that little fat pad will move around with the ventricle in contraction. What they're looking at here. Pleural effusion. Yeah, that's a pleural effusion. As you all know, distinguishing that from pericardial effusion. Pericardial effusion tends to be between the descending aorta and the heart right here, while the pleural effusion tends to be behind the aorta. What is that? These are not normal variants. These are more like things that you can see beyond the heart. Yeah. Yeah, that's just a spine. It's a very prominent spine shadow, but sometimes can raise an eyebrow for people who don't see it commonly. Okay. What is that? Pardon me? So this is actually a hiatal hernia. So this is the left atrium, as it's struggling a little bit, but this giant black area is actually part of the gut. Most of the time it's fine, but as you can imagine, if it's compressing on the left atrium to this extent, it can cause symptoms of syncope, exercise intolerance, and even hemodynamic compromise in certain scenarios. But the question is, how do we know if it's a hernia? Yes, exactly. It's a different kind of bubble study. Just give them a little bit of soda. You should see bubbles in the stomach rather than in the heart. Last one. What are we looking at here?
This is the lung.
Yeah, that is the lung. So there's a hepatization of the lung tissue. So it looks almost like the liver, as in the subcostal view. It generally indicates underlying lung pathology as demonstrated on this following CT. This patient had lung cancer and then pneumonia on top of it. All right, so some take-home messages. So the normal variants have varying degree of prevalence, but can be seen quite commonly on echocardiogram. So some things are more common than other. They generally have embryological basis, as I hope I've demonstrated to you. Some of them are fairly easy to distinguish based on the view, but in certain cases, it can be quite challenging, as you saw that some of those cases actually require further imaging in order to delineate them better. They're generally benign, but can cause trouble in certain scenarios. So I do think they're worth noting if you do see them on echo to comment. So here's some references. Thank you, everyone. And huge thank you to all the echo fellows who helped me put this together, and Dr. Chow for supporting me on this one.